Good evening, doctors. On behalf of Harmonica Acumentis, myself Shubhojit Mukherjee, welcoming you all. And it's a pleasure for me to come to the fifth episode of this masterclass in endometriosis. Before I just hand it over to Dr. Naren Malhotra, a word or two about the company. Doctor, I take pleasure in introducing to you Acumes Drugs and Pharmaceutical Limited. Incidentally, this is the largest contract manufacturing company in India. This is our parent company. The organization deals in the manufacturing and export of formulation in a wide spectrum of dosage forms and therapeutic segments. The company is currently supplying to almost all Indian and multinational pharma companies across the globe. Doctors, I take great pleasure in announcing that most of the brand you are using are manufactured at our Acumes plant. Dr. Acumentis is the sales and marketing wing of Acumes. Next slide. And our mission in Acumentis is to become a global healthcare company, empowering each and every patient on earth with novel healthcare solution to fight the discomfort. Next slide. We have 9 strategic business units. Of course, women's health is the main business unit, contributes a major part of the business. Apart from this, we have cardio, diabetes, orthopedia, derma, and general. Next slide. And our division is called Harmonica, which signifies brings back harmony to life. And Harmonica is a division that is serving women's health through gynae and IVF, doctor. This is in a nutshell about Acumentis, and of course, we deal in medical management of fibroids, medical management of endometriosis, medical management in PCOS, and of course, IVF therapy. So that's in a nutshell about Harmonica. And once again, good evening to all, and myself Shubhojit Mukherjee as BU head Harmonica Acumentis would like to thank FIGO and REI committee for bringing 6 online modules of an continual medical education program, masterclass in endometriosis. I take great pleasure today in introducing Professor Narendra Malhotra, the chairperson of today's program. Dr. Malhotra is Director, ART Rainbow, IVF Agra and Delhi. He is the Managing Director, Global Rainbow Healthcare, Director, International Relations, Suffolk, President in SAR. He is the Professor, Dubrovnik International University, Sarajevo School of Science and Technology, VP WAPM, which is the World Association of Prenatal Medicine, Vice President Suffolk from 2019 to 21. Dr. Malhotra is the past president, ISPAT and ISAR. He is the member FIGO Guidelines Committee, President FOXY 2008 to 2009, Dean ICMU 2008. Dr. Malhotra is the director, Ian Donald School of Ultrasound, which is an Indian A, and of course, he is the National Tech Advisor for FOXY GOI MacArthur Foundation EOC course. So over to Dr. Malhotra to take over the proceedings.
Thank you, Dr. Shubhajit. Welcome, delegates, to this great fifth episodes we have had done by the FIGO REI committee for us. And the masterclass has shown 6 module program. Today we are on the 5th one. Can I have the next slide? And the module 1, the speaker was Professor Linda Goodies, 7th of June 2021, endocrine environmental disruptors. A fantastic talk which she gave, and I'm sure you have the printout of this, and I'm sure you also have the YouTube link to it. If not, we will be giving you to listen to all these lectures. Module 2 was Mary Loie Hull, 6th of July 2021, challenges in understanding the pathophysiology of endometriosis. Again, so beautifully the pathophysiology was explained that it becomes very clear on how endometriosis develops. And then we had none other than Professor Dr. David Adamson from USA, a person whom we admire a lot and who's helped in guiding me and Jaideep to a lot of things. Dilemmas in diagnosis and management of endometriosis. And Davidson's score and all, we all know. Module 4, Edgar Mocano, again a fantastic speaker, managing endometriosis in infertile patients, and how he beautifully compared the medical management and preferring GnRH in where pregnancy to downregulate immediately, and then also now comparing with the Dynagist for 3 months after surgeries. And today we have Dr. Jaideep Malhotra, who will be taking over as the chair of the reproductive endocrine in an infertility committee of FIGO tomorrow. And yes, FIGO conference starts tomorrow online. And the module 6 is Rui Farani, the first week of November, which you will be hearing on controversies of deep endometriosis and infertility. So these are the 6 modules which we designed for all of you. Next slide. And let me introduce today's topic and today's course coordinator, the current FIGO chair for the Reproductive Endocrine Committee, that is Dr. Yvonne Diaz Yamal, and my co-chairperson, Professor Pratap Kumar, and Dr. Jaideep will be the speaker. Next slide. So let me introduce these experts to you. We first have Dr. Yvonne Diaz Yamal, MD COG, and there you are, Yvonne. Very, very good morning to you. We are here in the evening here. She's a gynecologist and obstetrician and specialist in human reproduction, and a professor at the Military University, head of the Department of OBGYN Human Reproduction at the Military Central. And she's just a fantastic person personally also, and we have had the pleasure of knowing her since a very, very long time. Congratulations on a very, very successful tenure you've had as chair of the Reproductive Endocrinology and Infertility Committee. Next, please. And yes, we'll just, and my co-chair, Professor Pratap Kumar, the head of the department from Manipal, a very, very close friend. Pratap and me have grown up together in Foxy and FIGO and everywhere all over the world. And Pratap and me have revised the Jeffcott textbook of gynecology together, and we've done lots and lots of projects together. Pratap Kumar is an excellent teacher, a fantastic clinician, and a superhuman being. Welcome to this meeting, Dr. Pratap. I now hand over the mic to Dr. Yvonne to introduce the speaker and to start the session. Dr. Yvonne, all yours.
Hi everyone. For me, it's a pleasure be here with you. For FIGO, this mastercard is very, very important, and our committee is successful. This masterclass of endometriosis, and the other way for me is most pleasure because my friend Jaideep is our next chair in the committee, reproductive medicine, infertility, and endocrinology, FIGO. Jaideep, congratulations.
Thank you.
It's very amazing. Half and woman, how you leadership in all world and of course in India. Congratulations again. Jaideep is a medical chair-elect FIGO Committee of Reproductive Endocrinology and Infertility, Management Director in Rainbow IVF, past member FIGO Working Group in Reproductive Development Endocrinology, member accountability group in PMHI, WHO, past president in the Federation in India, President, Vice President India Society Anesthesia and Generative Gynecology, Regional Director South Asia in Donald School USA, Professor Dubrovnik International University Croatia, Editor-in-Chief the journal in many books, member of FIGO Committee Reproductive Endocrinology Fertility and Working Group in Reproductive Development, is Lifetime Activity Award in Amar in India. Is all many congratulations and many awards records in India awards. Thank you, Jaideep, and welcome for this conference.
So we begin today's talk by Dr. Jaideep Malhotra on ovarian stimulation in protocols in endometriosis and ART.
Thank you so much, Yvonne and Pratap and Naren. And thank you, Acumentis, for this opportunity to, host this masterclass under the aegis of REI Committee of FIGO. And I think we've had phenomenal success as far as this masterclass is concerned. And I'd like to inform everyone that we are going to continue these activities in the years to come also. And there are many things which we are planning. I would like to place on record my sincere thanks to all my predecessors. Wonderful, wonderful topics which have been covered. And today I'm going to cover ovarian stimulation and ART in endometriosis. Now, this is one of the most important area as far as reproductive age group is concerned for endometriosis patients, because it really poses a very complex and challenging and an elusive disease, as we all know. And as Socrates put it, I neither know nor I think that I know. The more we know, the more we think that we don't know. And that is what endometriosis has posed on us. It comes across as a very common inflammatory disease in the reproductive age group. And we know that there is a sustained reduction in ovarian reserve by both physical and inflammatory reactions. And also there's a lot of role of reactive oxygen species and tissue fibrosis which happens. And a lot of research is actually going on in our understanding to be improved. But what we have definitely understood is that roughly about 25 to 50% of the infertile women have endometriosis, and about 30 to 50% of the women with endometriosis are infertile. Now, when it comes to management of infertility, basically in this group of women who have endometriosis, the first question which I ask is there any role of expectant management of endometriosis? Because there are bigger challenges. We know that we have to shift over to ART as soon as possible based on many studies, but there is an evolving role today as we are understanding the disease further. So in this particular very interesting publication, I'd just like to point out here that yes, for non-infertile women, please understand, for non-infertile women who are planning to seek pregnancy in the presence of an ovarian endometrioma, expectant management is a reasonable option. And that is something which most of the infertility specialists do not really think about. And these are women who have had, spontaneous pregnancies before they actually showed up with endometriosis. On the other hand, the infertile patients, spontaneous pregnancy rates without treatment are very disappointing. And in those patients, surgery-assisted reproductive technology or a combination of two may be suggested. And that is something which I would like everyone to understand. Now, in a very recent publication this year itself, again, when I asked the same question, the answer is also very interesting. Now, infertility management according to the endometriosis fertility index, which has been formulated by none other than one of our speakers, David Adamson, who was the past chair of REI Committee of FIGO. And based on this analysis, it was suggested that if there is an unfavorable endometriosis fertility index, which means that if it is less than or equal to 4, more and more patients will actually be achieving ART pregnancies, suggesting that we need to sort of refer them for ART shortly after the surgery, which is important. But if the fertility index is favorable, which means if it is more than 5 or equal to 5, then patients may try for spontaneous pregnancy for 24 months before referral. Now, this is really important. Now, the next question which I ask is IUI a reasonable treatment for endometriosis? Because I myself was of the opinion that if there is a moderate to severe disease, IUI is not a feasible option. But today, we do understand that there are now number of RCTs which are coming up, which are saying that if there is a moderate to severe disease, but the ovarian reserve is still normal, then IUI could be a feasible option. But if you're looking at IUI, then definitely the results are better when we do a controlled ovarian stimulation, where the results definitely improve, as we have seen based on this publication. So when we go ahead and now look at, because there are not many studies assessing the efficacy of IUI with or without ovarian stimulation in endometriosis. There are very, very few studies which are available. But whatever is available today, and what we understand is that yes, IUI can be a feasible option, but whenever you are looking at it, ovarian stimulation is something which should be considered for better outcome. Now, what I have put here on in the gray box is from the ASHRAE guidelines, which are there this year. The draft is ready and it is there on online for people to see, read it, and then maybe send their suggestions. And what is suggested by this ASHRAE guidelines is that in infertile women with AFS or ASRM stage 1 or 2 endometriosis, clinicians may perform intrauterine insemination with ovarian stimulation instead of expectant management or IUI alone, as it increases the pregnancy rates, and time to pregnancy is something which we always look forward to. And the second important aspect is that although the value of IUI in infertile women in stage 3 and 4 endometriosis with tubal patency is uncertain, if performed, the use of ovarian stimulation should be considered. So this is something which is now with the recent publications and the data which is there, which I wanted all of you to understand and maybe give the options of IUI or expectant management wherever it is validated by the endometriosis fertility index. Now, that is something which all of us should be really looking into because it's very reproducible and cost effective. Otherwise, we all know the indications of ART in endometriosis, and I'm not going to go into the details. But we again understand that in endometriosis, there are many factors which are playing. So alteration within the follicle, the poor oocyte quality, the subsequent embryogenesis is affected. There's a decrease in the endometrial receptivity, and there are a lot of altered progesterone and cytokine concentration which is playing its roles. And a lot of times we have seen that the embryos tend to develop more slowly as compared to the normal controls. And women with endometriosis have a normal receptivity, and the pregnancy rates with donor oocytes are pretty much okay. While the oocytes from endometriosis women, when they are donated to normal women, the implantation rates and the embryo quality is definitely much lower. Because as we understand that there are as many factors are playing, inflammatory reaction is something which is very much there. Increased number of immune cells are there. Then there's mechanical damage which is there. And all these oocytes which are retrieved, the mitochondrial content, the dark granulation, spindle abnormalities, and the zona pellucida hardening, they're all visualized in these. And because of these altered morphology and lower cytoplasmic mitochondrial content, these oocytes don't do very well when we go ahead and do in vitro maturation for them. And the result of this meta-analysis, which came up in 2017, actually addresses that there is a reduction in the number of mature oocytes retrieved in patients who are associated with endometriosis, and also there is a reduction in the fertilization rates. So how does endometriosis affect fertility? If you're looking at women under 35, you'll see that women with endometriosis, have twice as likely to experience infertility than women without endometriosis. The fecundity rates are also much lower compared to normal women. And there are many contributory factors which we have already discussed. And thus, their options of medical and surgical management are already there. But as today we are going to discuss on assisted reproductive technology, I would like to inform you here that there are actually not many randomized trials evaluating the efficacy of ART versus no intervention in women with endometriosis. But we have gathered a lot of indirect evidence on comparing the outcomes of ART in women with endometriosis to women without endometriosis. So ART can be performed for infertility associated endometriosis, especially if we have tubal function is compromised or there is male factor, and also based on the endometriosis fertility index, it is something which will help us in making our decision. Now, we categorize the disease in 4 stages, like stage 1, 2, 3, and 4. And we also understand that AMH levels in before surgery also are very significantly lower in women with severe endometriosis, that is stage 4, and then even when compared with mature cystic teratomas. Even from mild to minimal endometriosis, serum AMH levels, though they are not significantly different from the healthy control groups, but definitely moderate to severe, have a significantly lower AMH. And what is important for us to understand also is that endometriosis is associated with a much faster decline in the AMH levels. And that is something which we have to keep in our mind and not prolong the fertility option for long. So what do? We need to have surgical options available. Yes, surgery is the option, but routine surgical treatment is generally not recommended. Today, we have come to a conclusion that we need to avoid surgery as much as possible if fertility is something which is the concern. But if pain and other management is the concern, yes, surgery is definitely going to give you better results in those areas. But as far as fertility is concerned, surgery is something which should be very thoughtfully executed, because surgery actually causes ovarian injury, and that is one of our major problems as far as the ovarian reserve is being lost. So we use different techniques where you can do stripping of the endometriomas. You can basically drain the endometriomas, can coagulate the base. There's so many things which we do depending upon the expertise. But knowledge about what to do is also very important, because every effort has to be made to save the normal ovarian tissue. So if you're using electrocoagulation, the thermal damage is too much, which you will not be able to see, but all the surrounding tissue around where you are coagulating is going to be disturbed. And this affects in a decrease in the ovarian function post-operatively, because there's a lot of inflammation, edema, vascular injuries, and ischemia. And the long-term progressive decline is observed thereafter, which could be attributed to impaired vascularization. And what also has been seen is that there is a significant decrease in the AMH levels immediately after the surgery. And this remains low up to almost about 3 months. And then there may be some recovery if you have done a good job. Now, how can we take some steps where this reduction in the AMH is not as significant? Now, the 2 or the 3-step surgical technique, which has basically been described by Dones, which suggests that in the first look of laparoscopy, drain the cyst and irrigate it and take a biopsy and come out, and then put the patient on GnRH agonist for the next 3 months, and go back for a second look surgery after 3 months, and then perform the cyst wall vaporization. And with this technique, it was seen that there is much lesser reduction in the AMH and the AFC levels, and this probably would be one of the options which could be is a feasible option. The second option, a lot of times I have seen where maybe laparoscopy is not possible. Endometrioma, sclerotherapy can be done. And if we are basically comparing the two, it is a good option, but the recurrence rates are much, much higher in this. Now, the next, after all this, what we have done, we come to the challenges which we face in the ART, and there are many considerations which we need to understand. Now, as we are looking at the ovarian reserve, we know that if we have done a good job, even in spite of that, ovarian reserve is going to fall after surgery. So avoiding surgery, going ahead with ovarian stimulation and IVF is probably one of the options which we should be looking at. So if there is a unilateral endometrioma, the number of oocytes retrieved are not significantly different from when we have patients without endometriomas. So now this is a very important aspect which we should be looking at and understanding. So if there is a unilateral endometrioma, there's no need for us to go ahead and do a surgery for it. Go ahead and retrieve as many oocytes, freeze them if you want, and even going ahead and doing a transfer is something which we should be looking at, and there's not much difference compared to the patients without endometriomas. Now, this meta-analysis, which came up in 2015, reported that women who were actually undergoing endometriomas, who had endometriomas and were undergoing IVF without surgical management, had similar clinical pregnancy rates and live birth rates as compared to those without the disease. Although the mean number of oocytes which were actually retrieved were lower, and cycle cancellation was significantly higher in the group which had endometriomas, but the pregnancy rates were similar. So it is worth trying. While when we have a moderate to severe endometriosis, it appears to have adverse effects on the outcomes of IVF. Now, these are important because once there is a moderate to severe disease, then moving on to the best possible options is very much important as far as IVF is concerned. And sometimes, the reserves are so low that pooling of eggs and all those things may need to be looked into. Now, as we move forward, now what is very important is, and is very widely practiced, is the pre-treatment of IVF in endometriosis patients. Now, we have GnRH analogs, we have OCPs, Dynogest, and Cabergoline. Let us now understand how important and how useful these all molecules are for us. Now, GnRH agonists have been time tested because they downregulate the peritoneal fluid inflammatory proteins. They suppress the endometrial aromatase expression, and there are many things which they do. But the most important part for us to understand is that the negative effect of the disease process of fertility returns back immediately as soon as you stop or discontinue the agonist. And that is a big challenge for us. But what is important here again is for us to understand that in this Cochrane database analysis, which was presented by Salam, there were 3 prospective randomized trials which actually showed us that there was a definite significant improvement in the live birth and the clinical pregnancy rates wherever we gave a prolonged pre-cycle GnRH agonist treatment. And there was significant benefit in stage 3 and stage 4. So we need to treat stage mild and minimal disease differently than severe disease. But the loopholes which are there, now there are no comparative studies on exact duration of GnRH agonist pre-treatment. The prolonged suppression may lead to unresponsive patients, especially when there is a diminished ovarian reserve. There may be a requirement for higher dosage and duration of gonadotropins, and definitely there's a higher cycle cancellation rate. Now, what could be the answer for this? Now, we have beta-3 integrin. Now, once we identify beta-3 integrin may be this we will be able to identify patients who would need, a bit prolonged GnRH agonist treatment, and that is something which we can probably go ahead and do. And otherwise, if we are looking at administration of GnRH agonist prior to ART treatment to improve the live birth rate in infertile women with endometriosis, it is not really recommended as the benefits are still very uncertain. So again, this is a huge eye-opener, and this is again from the ASHRAE guidelines, which are there right now online, the very recent ones. Now, whether agonist or antagonist. Now, since antagonists have come up and because they are much more patient friendly, the shift has happened to the antagonist cycles almost all over in the ART circle. Now, agonist today, we are realizing after using antagonists for many years, still has some role to play, especially in many different subsets. Now, if you're looking at a mild to moderate endometriosis, both of them are equally effective as far as implantation rates and the clinical pregnancy rates are concerned. But if we are looking at a severe, moderate to severe disease, then maybe agonist is something which is going to give us much better results. Now, even with agonist, whether we are looking at an ultra long protocol or just a long protocol. Now, this publication which came up very recently says that GnRH ultra long protocol actually improved clinical pregnancy rates in the moderate to severe disease, while in stage 1 and 2 or minimal or mild disease, there was no significant difference. So here again, we understand that we need to understand where and to apply what is something which is very important. Let's come to the OCP's pre-treatment, again, which is very widely practiced. Now, the mechanism of OCPs is correction and suppression of the morphological and functional endometrial anomalies by suppressing ovarian function. Now, 6 to 8 weeks of OCPs actually produce similar effects induced by 3 to 6 months of GnRH agonist. So you require lesser dose and duration of gonadotropins, and scheduling can be done with OCPs quite well. But this Cochrane review and the author's conclusion was that women undergoing ovarian stimulation in antagonist protocols, OCP's pre-treatment is associated with a lower rate of live birth and ongoing pregnancy than no pre-treatment. Now, that's something which we again have to balance it out, whether we are going to sort of, take a little lower live birth rate or an ongoing pregnancy rate vis-a-vis give agonist, and the cost benefit may not be there. The next molecule on our armamentarium is Dynogest. Now, Dynogest is a wonderful, wonderful drug, which has really, made life much easier for us as far as management of endometriosis is concerned. But can we really use Dynogest in between period, right, from post-surgery to the time waiting period for ART cycles? And that's something which we have to, again, understand. But what we have seen in the ASHRAE guidelines here, that though it is something which can be used very well, but the data of evidence is really insufficient right now to recommend a prolonged administration of either COCs or progestogens as a pre-treatment for ART to increase the live birth. Now, please understand the words which are very important here. It is to increase the live birth, but wherever you have a time period in between, any one of these actually can be used. But in this publication very recently in 2019, what was noticed was that there was a reduced number of growing follicles, retrieved oocytes, fertilized oocytes, blastocysts, and cumulative pregnancy rates and live birth rates in patients where Dynogest treatment was used just before IVF. And that is something which needs a little more studies. Let's come to cabergoline. Now, cabergoline is quite helpful in decreasing the endometrioma size now, and can be very easily used, and these are the protocols which a lot of people are using. But as far as pregnancy rates are concerned, again, the recommendations are a little guarded. So women seeking pregnancy should not be prescribed post-operative hormone suppression only with the sole purpose of enhancing future pregnancy rates. And that is, again, as I said, please read it with inverted commas, because now when I come to the next part of it, when is it after a surgical intervention IVF should be carried out? Now, prospective and retrospective studies have happened. And in this particular study, which came out in 2018, what we have understood is that the ongoing pregnancy rates in patients who have had, surgery for endometriosis are significantly higher when IVF is performed between 7 to 25 months after the surgery. Now, initially what we used to practice, and in my own practice also I used to do this, was that as soon as surgery was done, we would put them on a long protocol or an ultra long protocol for giving a depot agonist injection for 2 months or 3 months, and then take them up for IVF after 2.5 months. But if we understand, the AMH recovery actually happens after 3 months. So probably, logically thinking, this is something which we should be looking at, and maybe larger studies can be carried out on this aspect also. Now, looking at the protocols for endometriosis. Now, all these were protocols only what I was actually discussing. We have many things which are available to us. The normal general protocols for IVF, they can all be applied to these patients also. Now, all and much depends on is what is the reserve of the patient, what is the extent of the disease, whether it is minimal or mild or moderate or severe, and what is the patient profile like. So ultimately, I would say that it is individualization which is very, very important for us, because those are some things which are very much concerning to the patient. Now, whether downregulating differently, meaning ultra-long protocol will improve the clinical pregnancy rates of infertile patients is important. And this is also very important for stage 3 and stage 4 endometriosis. These patients definitely do well with an ultra-long protocol. Now, how do you really predict which are the patients in whom what you will do? Now, AMH is one of the most clinically useful predictor of poor response in endometriosis, and that is something which we should definitely be assessing at. Now, once you have had the AMH levels in place, then individualization of the protocols is very important. Now, what we have understood again is from this study by Aflatunian and Hussaini is that AMH is a single test which has a very substantial accuracy in prediction of pregnancy using GnRH antagonist protocol for patients with endometriosis. And what we have understood is on the two extremes of AMH levels, antagonist protocol probably is something which would be more conducive, and otherwise we need to individualize the protocols according to the patient's need. Now, letrozole is another wonder drug. Now, in endometriosis, we need to understand that estrogen is produced by 3 pathways: ovarian, peripheral conversion, and ectopic production by the endometrial implants. Now, letrozole or aromatase inhibitors basically inhibit all 3, while GnRH agonist inhibits only the first pathway, that is the ovarian. And that's why letrozole probably, especially in normal responders, can be a good drug of choice, though letrozole may not be a very good drug of choice for poor responders where the granulosa cells are limited. So that is something which we need to understand, and individualization at that level is also very important. And this is what I was really talking about, that in moderate and severe endometriosis, the granulosa cells have reduced aromatase activity. Hence, altered steroidogenesis is there and impaired quality of follicular genesis and oocytes are there. And these can be aggravated by the use of letrozole in endometriosis. So this is one area where you would restrict the use of letrozole. Now, a lot of new protocols are coming up, and this is another one, which is the use of medroxyprogesterone acetate in women with ovarian endometriosis. Now, this protocol, normally what we do is that you choose your gonadotropins and the dose, and along with that 10 milligram of medroxyprogesterone acetate is given. It actually, prevents a premature LH surge, and it's much more patient friendly. And what has been seen is that the oocytes, the embryos, and the pregnancy outcomes were actually not influenced by the endometrioma surgery or by the presence of endometrioma. So this could be a good patient-friendly protocol to be used. Now, number of studies are coming up which could be reviewed, and I think they can be widely taken up. Does trigger make a difference? Now, we are all very used to HCG trigger for normal responders, and we are also used to agonist trigger for hyper responders. But here is something which I am now going to, there are a number of studies which have come up where a dual trigger is coming out to be much better, as far as, higher number of the cumulus oocyte complexes are being retrieved, and also the maturity of the oocytes is much better, where you use 0.1 milligram of agonist along with 1,000 to 2,000 units of HCG, and that's a dual trigger which is coming up with much better mature oocyte retrieval rate. Now, should we do IVF or ICSI for endometriosis? Now, a lot of times we have read, a lot of papers where we say that poor responders, number of eggs are lesser. Please, we cannot afford to have fertilization failure or triploidy. Please go ahead and do ICSI. But both IVF and ICSI are actually considered equally effective approaches to managing endometriosis in associated infertility. Now, there was also another thought process which said that the oocytes in endometriosis patients are very sensitive to ICSI-induced mechanical damage. Now, this study, which has very recently come up, this publication says that that's not really true, and if ICSI is required, then ICSI can be done, and these oocytes are not as sensitive to mechanical damage caused by ICSI. Now, as far as the results show for endometriosis, especially advanced endometriosis, we definitely understand that we retrieve fewer M2 oocytes and viable embryos, and also lower viable embryo rates and cumulative pregnancy rates are there in patients who have endometriosis than as compared to the controls. Now, wherever peritoneal endometriosis is there, in those patients, lower fertilization rates and lower viable embryo rates are there per oocyte. So hence, the pregnancy outcomes, though, may not be significantly different in these two phenotypes, but yes, the number of embryos for freezing are going to be definitely lower. Now, whether we should do a fresh or a deferred ET or a frozen embryo transfer is the next question which a lot of people ask. Now, endometriosis, as we understand, is an estrogen-dependent disease. So, modification of the endometrial gene expression, hence the receptivity, can be altered by supraphysiological estradiol levels in controlled ovarian stimulation. So, deferred ET or a frozen embryo transfer seems to be a very attractive option, and it has been seen that there were significantly higher live birth rates with deferred ET in this particular study. But a very recent publication has come up this year itself, which says that freeze all may not be a better option. Freeze all, not we can freeze for people and do frozen embryo transfers, but freeze all is not a better option, because if we logically think, the primary defect is in the ovary and impaired oocyte quality, as opposed to the defects in implantation. So that's why these patients do much better with donor eggs, and that is the understanding which is there. So fresh transfers can be considered in these patients if there are not much supraphysiological E2 levels which are present there. Now, on the last bit, when we are preparing patients basically for frozen embryo transfers, do we, especially in patients with adenomyosis, I wanted to touch this topic also, because in adenomyosis, again, the practice has been that you downregulate and bring the adenomyosis and shrink the uterus to a particular size by giving GnRH agonist and then do embryo transfers. And in this very recent publication, which they have compared two groups where GnRH agonist was given, and in the other only hormone replacement cycle transfer was performed, and it was seen that there was no significant difference as far as the pregnancy rates were concerned. And the other outcomes, including clinical miscarriages, ectopic pregnancies, for preterm birth and term birth, were also not significantly different in both the groups. So GnRH agonist downregulation based on hormone replacement therapy cycles may not actually increase the rate of clinical pregnancy or live birth in IVF patients with frozen embryo transfer with adenomyosis. Quickly, we are going to ask a few questions. Now, what is the probability of repeat surgery for recurrent endometriosis? Now, we all understand that if we have to do a repeat surgery, then the chances of having pregnancies are definitely going to be much lower. So we must understand that wherever possible, the second line conservative surgery should be considered only with very careful evaluation, because these women who have a desire to conceive, their chances of getting pregnant definitely are going to decrease. When we are doing stimulating these patients, does the process of IUI or IVF increase the progression or recurrence of the endometriosis? Is the next question which we normally ask. Now, the answer is no. With the number of studies which have different levels of evidence, if you can see here, which suggests that there is no significant progression of the or the recurrence of disease if we are in the process of stimulation or for IUI or IVF. Now, what about the risk of contamination and infection during IVF cycles? Now, endometriomas, we all know, contain substances which are really toxic for the oocytes, including metalloproteinases, cytokines, free iron, and reactive oxygen species. Now, there's direct evidence regarding detrimental effect of incidental follicular fluid contamination is quite scant and contradictory, but we know that contamination may reduce the fertilization rate and pregnancy rate, thus rendering it necessary to avoid inadvertent puncture of the endometrioma. And if it does get punctured, then wash the oocytes immediately, which is a standard practice in all IVF labs. Now, if required, though ovarian abscesses, very few cases are reported, but there have been reports. Then, to avoid that, you could actually go ahead and use some prophylactic antibiotics in case when an oocyte retrieval is happening with endometriomas. Lastly, we come to oocyte donation and endometriosis. We all know that these patients, especially who don't have a good reserve or the quality of oocytes is not good, they do definitely well with donor oocytes, and donor oocyte may be an answer for improving better outcomes in these patients. And lastly, this is the very recent study which has come up in June 2021, which sums it up all. Pre-cycle removal of endometrioma may have an adverse impact on the ovarian reserve. Pregnancy outcomes seem to be similar with or without surgery in patients undergoing IVF. So we are justified in avoiding surgery and taking them up for an earlier ART procedure to reduce time to pregnancy. Endometrioma surgery may be considered in the subsequent IVF cycle of patients with lower than expected ovarian reserve. Last but not the least, we have to talk about related oxidative stress, which happens in endometriosis. Now, we do understand that there is a role of chronic inflammation, immune system dysregulation, oxidative stress in the development and progression of endometriosis. And there is an increasing evidence in the role of reactive oxygen species and impaired mitochondrial function having deleterious effect on the ovarian reserve in patients who have endometrioma, and this actually could lead to a detrimental to the oocyte quality, and hence the embryo development is impaired. So as you can see here, it can work in various ways, and this is something which we are now, a lot of research is happening on reducing this oxidative stress and improving the outcome in these patients. Now, last but not the least is role of fertility preservation. Now, should we do it? Should we not do it? When should we do it? I would say that in a young girl, especially in an early disease, this is something which is a very feasible option. But in an extensive ovarian endometriosis case, as Eshre puts it, clinicians should discuss the pros and cons of fertility preservation with women. And the true benefits of fertility preservation in women with endometriosis still remain unknown. So this is a word of caution, but I feel that as times and understanding and awareness is going to improve, this is one area which will definitely go much further. Last, risk of ovarian cancer. Both endometriosis and ovarian cancer are E2 dependent diseases. So endometriosis increases the risk of ovarian carcinoma by 3 to 8 times. But IVF does not influence this risk. That is something we have to understand. So I'd like to conclude here, and I think I have given some set messages for all of us to follow, because these are some guidelines which are based on a lot of data and evidence and research which has been carried out by the world. So surgical treatment and subsequent IUI with ovarian stimulation should be considered in women with minimal or mild endometriosis with infertility. In women with moderate to severe endometriosis, surgical treatment can reduce ovarian reserve and adversely affect the subsequent IVF outcomes. Surgical excision is not routinely recommended before considering ART. Clinicians are advised to assess ovarian reserve prior to deciding whether to surgically remove endometriotic lesions. Individualization of the care provision has to be kept in mind when we are dealing with endometriosis and IVF, because priority is for the pregnancy outcomes. And fertility preservation options should be given to young women with endometriosis in early life after discussing the pros and cons. Thank you very much for having me. And I would say endometriosis has genetic predisposition. Endometriosis also has environmental predisposition. And I think the onus lies on us to protect our reproductive health now and for all generations to come. Thank you very much for having me.
Thank you, Jaideep. Wonderful talk. You brought in a lot of important issues which can be discussed. Already, I got many questions on the chat box which I'm going to ask you. Dr. Narendra, shall I start or you want to start?
Oh, yes, please, you carry on.
Yeah, the first question is it is by Dr. Shakuntala from Mumbai. She's asking about fertility index, EFI, endometriosis fertility index in your center. Do you follow that? And she also says that more than 4 scoring, the non-ART pregnancy may be the same time, or I can wait for quite a long time. At the same time, there's one Dr. Shubara from Manipal asking the same question. She also said that EFI, as opposed to those with more than 4, decision can be taken faster. What's your opinion about EFI?
Sorry.
Endometriosis fertility index. Are you
Yeah,
following it?
Pratap, actually, I have to be very honest with you. We don't follow the endometriosis fertility index because here, with the major issues are that everyone has to be on the same page, and it needs to be, laparoscopy has to be done. Done multiple factors which need to be considered. But after when I once, met David and we have been talking about it, and after reading all these present publications which I have, I am very much convinced today that, especially, I'm honestly telling you, I was of the opinion that once somebody has endometriosis, moving on to ART is the most important thing, because the decline in AMH is very fast. But today, when I have read so much of these publications which are there, expectant management and IUI also has a place, and you cannot do it unless and until you have a validated EFI fertility index done. So this is
Correct.
something which I would really encourage my own team and also everyone who's listening to me to follow.
I agree with you 100% because though the index is there, I think we should be more practical about choosing either IVF or IUI depending on the findings, what we say. There's another interesting question by Dr. Prashant Tadiga from Manipal. What do you do when you find an endometriotic cyst which is buried in dense adhesions and not amicable to cystectomy?
I'm going to tell Naren to answer this because he is the one who's mostly doing it. And we most of the times we are fighting with each other because as a surgeon, lot of people would go and put a needle and aspirate. And
Yeah.
sclerosing therapy is also something which has been tried, and recurrence rates are quite high. Of late, I would say in the past 3 or 4 years, I am not referring any of these patients for a laparoscopy. We are going and ahead and stimulating them. We are freezing the embryos. If there is a severe, moderate to severe disease, we put them on agonist for 2 or 3 months and then go ahead and do the transfer. But
Yeah,
there
I
is
think
another
so.
school of thought which Naren follows, so I would like him to
Naren,
answer this.
you unmute yourself, Naren.
Now, Pratap's question was that when I'm doing a laparoscopy and I cannot reach the cyst because of dense adhesions, so
Yeah.
removing dense bowel adhesion, you have to have a bowel surgeon with you and full bowel preparation. So that makes it a very extensive surgery. Now, if it is not, see, if she's coming with pain, we have to do something. So those adhesions would be causing pain. But if she's come for a pre-IVF just to reduce the cyst, then I would go ahead and do transvaginal draining of the cyst. I wash it with saline and put escarole, 2 ampules of escarole foam in the cyst wall and cause sclerosis. And yes, recurrence is there, but 30-40% of the time it doesn't recur. So it's quite a successful 30-40% only by needle and sclerosing agent is quite a good treatment where
Oh.
nothing else can be done.
Yeah, that's interesting, but I think Jaideep has also the opinion that I think we can do the oocyte pickup and then get maybe check on the cyst later. But there's another interesting question. You mentioned about GnRH analog suppression. Let us say you're done for 3 months. Don't you think there'll be over suppression of the oocytes?
Yes, it does happen, and that's why the cycle cancellation rates are higher in especially patients who have diminished ovarian reserve. So I would really say that we don't really do very ultra long suppression. We would give them for maybe 4 to 6 weeks. The general protocol which we follow is that we'll give them one shot, and once we have given them the second shot, after 15 days we start stimulating them, and under
Yes.
the effect of that second shot only, we do the ovum pickup.
Yeah, that's interesting because even I follow that I can actually give 3 doses, but I don't wait for the menstruation to come. I about 3 weeks, as you said, 2 weeks. I wait for 3 weeks after the last dose and then the stimulation. I think that's an important issue because if you wait for the menstruation to come up, they will again have a recurrence. 100% agree with you.
Also,
Now, do you
Pratap,
think
another thing
that
I would like to point out here, because I have extensive experience here. I don't know whether you remember or no, right from day one, I was using GnRH agonist long protocol depot injections being given 25 years back. People used to come and say, oh, the dose is, increased. I never faced that problem at all because my patients were ones who could not take injections daily. So daily dose was something which was out. But uh, when the kind of agonist which you are using is also very important because what molecule you are using, whether you are using triptorelin or a leuprorelin or a goserelin, because the stronger molecule which you use, then you have to sort of adjust accordingly. But if you're using leupride and all, then after the second shot 15 days, it works very well.
Yeah, thank you. One more sub question is that when you give a suppressive dose and you start stimulation, what is the dose of HMG you would like to start with for IVF?
Normally 300 units.
So doesn't it depends on the antral follicles at that time, or you don't go
I
beyond
normally
300?
do not take a chance because most of the times the reserve is not very good. We don't know the FH threshold of these patients. I don't follow the book, especially from the Western, because here patients are paying. And if the response is not there after 5 days, because they take the injections home and they come back after 5 days, if the response is not there, we've lost on the cycle. So I normally start with, especially based on let's say a normal or a poor reserve, I'll start with 300, and because most of these patients do not have a very good reserve, so
Correct.
and I've never had any problems.
Yeah. I think so. Depending on the case, you can choose. But my experience is when you do the anti-Mullerian hormone, it goes down after surgery. But after 3 months, I'm finding it back to normal. Did you find like that, Naren and yourself, Jaideep? AMH going back to normal.
Pratap, it actually depends on the extent of the disease and the surgery performed, how difficult the surgery was, what kind of a surgery which was required, whether you were whether the cyst lining was stripped well, or you needed to do some extensive, electrocoagulation. So it all depends on the type of surgery which has been conducted. But yes, there is a definite recovery after 3 months, and but
Yeah.
it is basically directly proportional to the kind of extent of disease and the surgery performed.
Excellent. There's a nice question by Dr. Ashima Sood from Jalandhar. Is surgery the only answer for deep infiltrating endometriosis, or do you have any alternative?
The next module is on deep infiltrating endometriosis, where Rui Feriani is going to, give you all the insights. He has number of publications, so please look forward to it in the first week of November.
Yeah, I think that will be better to wait, correct. Dr. Babita Verma has asked one question. Endometriotic patient receiving embryos from donor oocytes, what precautions to be taken? And if endometrioma is present, can we go ahead? About donor
Donor
egg, can we do
oocyte,
donor egg and the,
donor is a proven option for extensive disease in a patient. So I don't see any reason for us to worry about that. Because once a patient gets pregnant, the chances of her getting pregnant with donor oocytes are much better than her own eggs. But when I say this, it does not mean that any patient who has endometriosis, you will go ahead and do donor egg. Now, there has to be a proper indication for that. So please, understand this, because ethical practice is something which is the most important thing I would really urge all of you to practice. So please do not jump to conclusions. As we have said, that you can retrieve eggs with endometriomas. No surgery is required unless and until the endometrioma is coming in the path of your needle, or if the patient is in extensive pain, or she has other symptoms with endometriosis, those are the times when you would go ahead and do surgery. But if the normal ovarian tissue, when you do ultrasound, if you visualize the normal ovarian tissue accessible by your probe, go ahead and stimulate her.
Excellent. There's another question from Dr. Ashima Sood from Jalandhar. Is recombinant FSH preferred over HMG?
Sorry, recombinant over
Recombinant
HMG.
FSH over HMG, yes.
See, again, Ashima, it depends upon the reserve. So we normally say poor reserve patients, you would go ahead and stimulate with HMG. If you're using GnRH agonist or ultra long or long protocol, then also you will use HMG, because if the LH, basal LH levels come down below 1 international unit, then the steroidogenesis is not good. And you need both FSH and LH for steroidogenesis. And those are the patients where you would use HMG. But otherwise, in a normal antagonist protocol, FSH is also good enough.
Yeah, Dr. Madhu Gulati has complimented you for excellent presentation, and Dr. Anju Kumar too. Another question by Jyoti Dixit. Once endometrium is excised and recurrence is there after a few years, what should be done?
See, Jyoti, again, we have to understand what is her problem. If fertility is her problem, I had put the last slide on only for this purpose. Please refrain from doing a second surgery, because her reserve is going to go down and her chances of getting pregnant are going to be much lower. So your idea should be to retrieve as many eggs and pool oocytes if the reserve is poor, and then maybe take care of her disease later on.
Yeah, I have another question to you. Like you spoke beautifully about oxidative stress and inflammatory processes. So now the oocytes are definitely not too good. That means with all this kind of action, do you find the follicles nearer to the endometriotic cyst also behaves like that? Follicles are little above the cyst, very close to the.
You know, Pratap, when you are actually doing an ovum pickup, each and every tube, I mean, I haven't done that research that yes, this was the follicle which was right next to the endometrioma.
Yeah.
Can you see what is the oocyte quality? Because they all go in one pool. So it's difficult for me to
Yeah,
answer. Logically
yeah.
speaking, they should be affected.
No, I
And
have
we
been trying to do
definitely do
that.
that.
I've been trying to observe that. We are yet to do
Yeah.
a complete study because all the
But you
follicles
know
are
what
just.
I was saying, that we have seen when contamination happens. So
Yeah,
we put all those
there's
set of
no doubt
oocytes
about that. It's like the
separately.
neighbor story. It's like a neighbor story. If the
Yeah,
neighbors are not too good, there's some effect on us. So something like
yeah,
that. So,
yeah.
Narendra Malhotra, do you want to ask some questions to Jaideep?
So I'm okay. I think she's covered everything, and she's even asked in the last 5 6 slides the questions and answered them also.
Very
Very
good.
proud
But
of her.
one question is still there. What's that you
Yeah.
said about dual trigger about and then 1200 HCG? But even otherwise, what's your dose of HCG for an endometriotic trigger?
You know, in my practice, I actually have never given, we use 250 micrograms of recombinant HCG as a trigger, and otherwise 2 milligram of leupride if you are using an agonist trigger. Um, I do not practice dual trigger in my clinic till date, but I know the clinics who are, you know, using a dual trigger, and they are telling us, and even these publications which I have presented today, they are definitely telling us, you know, a different story. So once I try, I'll be able to tell you much better. But we don't really practice dual trigger, and I do not give 10,000 units because all my life I've only used recombinant HCG, which is 250 micrograms is equivalent to about 6,500 international units of
Exactly.
HCG. And
Hello, Dr. Yvonne. Do you want to ask Jaideep
Yeah.
something? Yvonne,
Yes.
how are you, Yvonne? Yeah.
Yeah. More of a question is comments. We work in FIGO for the prevention in infertility. And I think the most important when a woman have endometriosis is the prevention her infertility with the cryopreservation of sites because that's the best way for have a pregnancy in the future. Of course, when it's not possible that, of course, we need to make the stimulation and in vitro fertilization. But the most important when we have a woman with endometriosis and endometrioma is the possibility for make the cryopreservation and prevention infertility in the future. What do you think, Daidi, about that?
Yeah, Yvonne, I do agree with you. But fertility preservation, if I have understood you correctly, uh, especially if the disease is there in young adolescent girls or early reproductive age group, especially career women who do not want to have a child because they're still establishing, it is the only option, and we must help them out. And I think and we do it in our clinic also. But when I read the ASHRAE guidelines, now these are all based on the meta-analysis. So they're still, trying to weigh the pros and the cons, and they are still not very sure based on the meta-analysis which are available, whether it is a really feasible option. Now, this is important for us to understand because we individualize in our country, we individualize treatment and it is patient-based, while in the Western countries, and I don't know about your country, but I know USA and the Europe, it's all driven by insurance and the medical cover and the health schemes, and that is where they weigh the cost effectiveness of a particular technique. But if the patient is paying and they want to go ahead and preserve fertility, the options are open all over the world.
Correct. Yes, I do. Thank you.
Yeah, I think all the questions have been answered extremely well as the lecture was fantastic. So, Dr. Narendra Malhotra, would you like to say to conclude?
So thank you, Dr. Jaideep. Thank you, Dr. Pratap. Thank you, Yvonne, for being here and organizing this great masterclass module 5 today. And we will see you in November on a date for the last one of this series of masterclass and many, many more to come. Thank you very much. Thank you, Subhajit, Acumentis,
Subhajit?
Harmonica, for being our technical partners.
Thank you.
Thank you, sir. And I would really like to thank Dr. Jaideep Malhotra for sharing her clinical experience and time taken for this program. And also thank Dr. Yvonne for being the course coordinator. Harmonica Acumentis thanks Dr. Jaideep Malhotra for her guidance and help in bringing the FIGO REI certification program on endometriosis for our Indian doctors. I also take this opportunity to thank Dr. Pratap Kumar and Dr. Malhotra for accepting our request and participating in this program and expressing their extensive clinical experience to our participants. Thanks to all viewers for joining this educational program of FIGO on endometriosis, and request all to attend the MCQs which will go after the next session. Last but not the least, we would like to thank DocMore Health Technologies for being the technical support, and we look forward to each one of you participating in the next and final module of this FIGO RAI masterclass on endometriosis in November first week. Thank you very much once again, and thank you, doctors. Thank you very much. Thank you.
Bye bye. Thank you so much.